So after sex comes babies, and we have
sometimes, not always.
So we have Kristen Smith here, who is the patient navigator for fertility preservation here at the Lurie Cancer Center. And she takes care of young, newly diagnosed patients here at the Cancer Center, and also answers questions on the national FERT line through the Fertility Consortium to help counsel patients on fertility issues, preserving their fertility. So I'm going to hand it over to Kristen Smith, who's going to talk about fertility with cancer patients.
Oh, that's not the right. Yep, didn't put it in the USB port, so that's a problem. In true fashion, for those of you who know me, I did not turn my slides in like I was supposed to. Sorry, Kate. So we're uploading them now, so I can go through a few of them without actually seeing them. My name's Kristen Smith. I am the patient navigator here for fertility preservation, and basically that means that I'm the middle person. So I'm the person that sits in the cancer center, but I'm paid for through fertility and see both men and women. Patient navigation, if you didn't have one during your treatment, is kind of a hot new buzzword in healthcare, and it's really just someone who can get you from points A to B to C in a quick, expedited fashion without hitting all of those barriers. Let's see, there we go. This one. So we all know that lots of different treatments can impact your fertility. So things like chemotherapies, radiation therapies, and specifically certain surgeries can impact your fertility. Sorry, it's totally my fault. You know, and we're super fortunate here that we do have what's called the Fertility Consortium. So this is a group that was started by Teresa Woodruff, whom you heard mentioned earlier. And Teresa really kind of put these two worlds together. So she saw this unmet need specifically in women, sorry guys, but specifically in women. We weren't doing nearly enough to talk about fertility concerns at initial diagnosis. So she actually coined the term oncofertility by putting these two worlds together, and also created the National Physicians Cooperative of the Oncofertility Consortium, which is a group of medical centers all around the country who really put fertility as part of the cancer journey and ensure that their patients get this fertility discussion, and sometimes also offer different experimental treatments that we all work on together. So this is really for men, the medical side of things. You need quite a few things in order to make sperm. So you need some luteinizing hormone and follicle stimulating hormone to come from the brain. That then goes down to the testicles, where you have Leydig cells, and these are the cells that actually make testosterone for men. That testosterone then stimulates the Sertoli cells, which stimulate the spermatogonial cells and actually make sperm. So when we're concerned about how treatment is impacting male fertility, what we're most concerned about are those spermatogonia cells, the cells that actually make sperm. Typically, the cells that make testosterone aren't too badly impacted. Now, when we talk about radiation, certainly those cells as well can be impacted, and we know through lots of studies that are being done down at St. Jude with the Childhood Cancer Survivor Group, we're starting to learn what doses of total body radiation, what doses of testicular radiation really have the largest impacts on fertility and on testosterone production. When I first meet with guys who are getting ready to start their treatment, or sometimes in the middle of treatment, we go through all the options for fertility preservation. The gold standard is sperm banking. It's usually pretty easy. So guys come to the urology clinic, they have a quick office visit, they get a physical exam. We do baseline hormones so that we have those levels to begin with before treatment. Then they go into a collection room, and it is just like what you see in the movies. Ours are a little more high-tech now with all video, no paper. And they basically masturbate, produce a sample for us. We analyze that sample, and we are able to tell that guy more about his sperm than he has ever wanted to know. So he knows his sperm counts, he knows his motility, or how the sperm are moving, and he knows his morphology, or how the sperm are shaped. Oftentimes we'll have folks bank 2, 3, sometimes 4 or 5 times, hoping that we can get really as many vials of sperm saved. And, you know, some guys, one time, they can give us 10 vials of frozen sperm. That's great. If it takes us 5 times, totally fine too. It just means more visits to our collection room. If someone's unable to masturbate or unable to give us a sample, we can also sometimes go in and do a surgical procedure called a TESE. It's a testicular sperm extraction. So Bob Brannigan, who's our reproductive urologist, is a wizard with this. He basically can go directly into the testicle, extract sperm directly from the seminiferous tubules that sit within the testicle, and then we can freeze that sperm. It's always much lower numbers when we're doing it this way, but for certain patients, this is it. And for our prepubertal boys, there's now finally an experimental option of testicular tissue freezing. So this is basically where we take a wedge resection of the testicle and we save the tissue. And the hope is that in the future, we can actually take this tissue and spin down those spermatogonial stem cells, so those cells that make the cells that make your sperm, and actually repopulate the man's testicle with this in the future. So this will, we're hoping, provide lots of options for our prepubertal, so our really young guys over at Lurie Children's who are getting hit with really difficult chemotherapy and radiation. So if you're sitting here and you're a male survivor, you've already gone through your cancer treatment and you're kind of wondering, where do I go from here? I would say find a local reproductive urologist. If you're around the Chicago area, Bob Brannigan is your man. He's your go-to. He's phenomenal. And what he's going to do is say, let's get a semen analysis, because he wants to check what's going on. If you're, got some sperm, but it's low counts, then simply we can refer you to reproductive endocrinology, where, if you've got a female partner and you're getting ready to have a baby, oftentimes we can help fix that. If there's no sperm found in the ejaculate, we'll try to do that surgical procedure. We certainly also talk a lot about utilizing donor sperm, so getting sperm from either someone you know or someone you don't know and what that looks like. We also talk a lot about adoption. If your hormones are off, so if the testosterone's a little bit lower than it should be, we can also do certain hormone replacement therapies, sometimes that are even fertility friendly. Now for the females in the room. It gets a lot more complicated for us when we talk about fertility. There's a lot more that goes on, and unfortunately, unlike men, we have a very finite window of fertility. So men can produce sperm well into their 80s, 90s, into their hundreds, which is crazy. But women, however, just naturally, we have this very finite window, so that once we start our period, so once we're, early ages, we are just losing eggs continuously. And up to that point, to before we've even gotten our periods, we've already lost a vast majority of the eggs that we have in our ovaries, and that amount we were born with. There's nothing that we can do to get those eggs back. When you have chemotherapy or radiation therapy, that's further decreasing the amount of eggs. It also screws with all of our hormones, and you kind of remember that picture of the guy where everything's very linear. The LH and the FSH do this, and then this happens and this happens. In women, it's completely out the window. So you get multiple ups and downs of estrogen, you get ups and downs of follicle stimulating hormone, progesterone, and you need lots of moving parts in order for all this to work together. When we think about chemotherapy, the way that we think chemotherapy specifically impacts female fertility is by damaging the cells that help support those eggs that we have. So the eggs are in a follicle and they've got all these cells around it. And we think the chemotherapy damages those cells that support it, and therefore it kills off that egg. When we talk about radiation, oftentimes what happens is it damages blood vessels that feed the ovary, all the great blood that it needs, and also as well can completely kill off those follicles. Surgery, obviously, if someone's having their ovaries removed, that's going to certainly impact the amount of eggs that are left. And this is something, if you saw me in clinic, you probably saw me whip this out, because it's sort of difficult to explain, I think, the amount of eggs that we have without having some kind of graph. And I'm very visual. So, this is usually what I pull out to kind of show the decline in fertility that women naturally have as we age. And then we talk about, okay, if you're 25 and you're getting cancer therapy, let's say it's non-alkylating agents, we don't think the chemotherapy is going to last very long, the doses are going to be that high. Maybe that means that your fertility window won't change very much. And we talk about that and why that's important. Let's say you're getting something with a single alkylator, not very much. Maybe that just means that your reproductive window is a little bit shortened. Maybe that means you're going to go into menopause a little bit earlier than your age-matched peers. If you're getting something like a stem cell transplant, so you're getting heavy doses of alkylators, total body radiation, sometimes that can mean that your fertility is gone after you're finished with that treatment, and there's really nothing we can do to get that back. But what's more difficult about women, and as we're looking into this field a lot more, we're finding that it really matters where you start. And not all ovaries are equal. So my ovaries might have way less eggs than the next 10 women who are next to me who are the same age that I am. And that makes a huge difference when we're counseling patients, is knowing kind of where those folks are starting from. And this is what I use to kind of show that you might be a more than average fertile person, you might be a less than average fertile person, and we don't know that unless we get some baseline hormone markers. When we talk about fertility preservation options, I bucket everything. What can we do before treatment starts? What can we do during treatment? And then we talk about things like after. Most of what's up here is the before and during. So egg and embryo freezing, where we stimulate a woman's ovaries to get lots of eggs, retrieve those eggs. We can either fertilize them with sperm if there's a sperm charming in the picture, or we can freeze the eggs in their unfertilized state. That's kind of mostly what we're doing now. Probably 40 to 50% of the women that I meet with are doing something like egg or embryo freezing. In certain cases where someone's getting pelvic radiation, we can do something that's fun to say. It's called an oophoropexy. Basically, we can take the ovaries and pex them or move them up into the abdominal cavity so that when that woman gets pelvic radiation, the ovaries aren't exposed as much. Then when she's ready to try for a family, if that's a possibility, sometimes we can unpex those ovaries and move them back down to where they started. In certain cases as well, we can do ovarian shielding. That's where the radiation oncologist will put some lead over the ovaries to help protect them a little bit. We'll talk a little bit more about ovarian tissue freezing, and then there's also this option of hormone suppression. So this is where we use a medication like Lupron, if you've heard of that, to basically shut down the ovaries during active treatment. And the theory here is that if the ovaries are nice and quiet during active treatment, then maybe that chemotherapy that's attacking and destroying those fast-growing cells that support the eggs, maybe it won't see those cells as much because they're quiet and it won't do as much damage. In theory, right, I nod my head to it because every time I say it, I'm like, it makes so much sense. The reality of it is a very mixed bag. So lots of studies have been published, very, very mixed results. For the most part, we tell folks it's certainly not going to hurt, but it does have some side effects. It puts you into a medical menopause. So all the sexual side effects we just talked about, expect those to come running down. Vaginal dryness certainly is one of the top. You can also expect things like headaches, moodiness, that kind of thing. So it's not entirely benign, but it's certainly an option that exists. Now, when we talk about ovarian tissue freezing or ovarian tissue cryopreservation, this is somewhat of a newer experimental option that women have. And this is basically where we remove an ovary, we isolate the outer edge, it's called the cortex, and we cut it into like these little strips that you see here. Then what we can do is, hopefully at some point, depending on the cancer, actually take those strips and sew them back together in what looks like a quilt. And we can actually transplant that quilt into her remaining ovary. The ovary recognizes its own tissue and will start to recruit and mature eggs. And to date across the world, there have been about 60 live births using this technology. Now, if someone had a blood-borne disease, so a leukemia, a lymphoma, an ovarian cancer, or they were BRCA positive, the last thing we'd want to do is take that leukocyte-rich tissue and put it back in her body because we could reseed her with her cancer. So in those particular cases, in the labs here at Northwestern, we're working on a technology, and it sounds like Frankenstein science, but where we can isolate some of those follicles and we actually grow them in an artificial ovary in the lab so that we can get just mature single-cell eggs that we could then fertilize. So this technology is really great for, again, our young girls who are at Lurie Children's who don't really have any other options for fertility preservation outside of trying to take an ovary and save that tissue. So for many of you in here, you're like, this is all great. Why did you tell me all this? I tell you this because a lot of you are survivors, and at some point you're going to connect with someone who's been newly diagnosed. And oftentimes, it's not been brought up yet. Fertility hasn't been discussed. And now you've got a little bit of base knowledge on what could that person that I'm going to meet, what could she do if she needs some fertility assistance before her treatment. But if you're sitting here post-treatment wondering, where am I at now? What should I be doing? You can start off with a reproductive endocrinologist, and what they're going to do is a quick fertility evaluation. So they're going to check to see, are you ovulating? They'll do some ovarian reserve testing. That's typically all with blood work. The biggest and kind of newest test that we're utilizing is called AMH. It stands for Anti-Mullerian Anti-Mullerian Hormone. And this is a hormone that's secreted by the cells, those cells that we talked about that support those eggs. And by getting that level, that gives us a really good idea of sort of the current egg count. And it's a number that we can watch over time to see how quickly that's going down. Lots of options after treatment in terms of building a family. If there's some ovarian reserve left and you've got a partner or you've got a sperm source that has fairly normal sperm counts, we can do something called an intrauterine insemination, where we trigger an ovulation and then we inject sperm directly into the uterine cavity to hope fertilization happens. If that's not working, we can move up to something called in vitro fertilization. That's where we get that woman to get as many eggs as she can and recruit them at once. We surgically go in, we remove those eggs, and then we fertilize those eggs, typically under a microscope individually to make an embryo, and then put that embryo back into her uterus. For some folks, they're not ready to get pregnant right now, but they know that that reproductive window is shortening. So for a lot of survivors now, we're offering egg or embryo freezing before they're ready to have a family so that they've got those kind of on ice waiting. There are certainly many options for third-party reproduction too, and you've already heard some great ones. So egg donation, sperm donation, embryo donation, use of a gestational carrier, as well as adoption. And I'm going to flip through these because I think I'm running out of time. Yep. So, when you're talking about trying to find an egg donor, typically you can go two routes. You can go with someone you know, or you can go with someone you don't know. If it's someone you don't know, you're going through an agency. So you're chatting with that agency. They're going to find an anonymous egg donor for you. It's usually a girl that's in her 20s. She's going to donate her eggs to you, and then those are yours to use. If it's someone that you do know, then there's a little more psychological screening that's involved. But, typically the cost is a little bit less expensive when it's someone that you know. Because egg freezing has gotten so good, there's also now the option, just like we used to do with sperm banks, to go to egg banks. So you can actually go to egg banks and you can get eggs. Typically they come 6 at a time, half a dozen, which is kind of weird. But you can get these frozen eggs and then they are your eggs. You have all rights to them. And again, it's usually a woman who's in her early 20s who's donated those eggs. When you're talking about embryo donation, this is another great option for family building, and there are lots of different agencies now that will help with embryo donation. Typically what you want to look for is that the couple who went through the embryo donation has been screened with the proper infectious disease testing, that they've gone through the right questionnaires, and that they had their history and physical, so that these are approved embryos for you. And oftentimes that agency will help take care of all of that. When we talk about using a gestational carrier, there's typically 2 routes. So you're going to hear people talk about surrogacy, and you'll hear people talk about gestational carriers. Surrogacy is typically where you're using that woman's egg and she's carrying. Oftentimes it's illegal. So there are many, many states where you cannot use a traditional surrogate. This was something that was done many, many years ago. Now with the technology of in vitro fertilization, where we can make embryos, you're more going to see gestational carriers. So this is where that person who is going to carry the pregnancy has no genetic link to the child that she's carrying. There's quite a lot that goes into it, as Alexis alluded to. It is a big process. Certainly there are many things in place. I actually asked Alexis to write down all of her challenges and issues, which she did amazingly well for me, so that we can really help make this process a little bit easier, because it is all encompassing, as they can both tell you. Also, I'll hit a little bit on adoption. There are many ways to adopt children. There's certainly the domestic route versus the international route. There's open versus closed in the domestic route, where you continue a relationship with the birth parents versus not continuing that relationship. Oftentimes now in today's world, if you are using an agency to go through adoption, that relationship is going to be more open. So the birth parents want to know a little bit more about kind of what's going on, and you get to kind of figure out what that communication looks like. Just some average numbers: about 2/3 of adoptions where you're getting a newborn take about 7 months and can cost around $40,000 when you're using an agency. There's also another wonderful way to adopt children, and that's through the Department of Children and Family Services. And I pulled this off of Illinois' website, that here in Illinois, there are almost 18,000 children in the foster care system, and about 3,500 of those children are basically just waiting to be adopted. And oftentimes these are sibling groups and school-age children. So it's very rarely a newborn, but this is another great option for building a family if that's something that you're comfortable with. And we all know this isn't easy, right? Nobody wants to go through fertility. Nobody wants to go through infertility. It completely sucks. So I want you to know that if this is a journey that you start, or if this is something that you're just beginning or in the middle of and you need help, let us know. There are lots of resources available to help with the emotional side of things, because this is a really difficult journey. And there are also lots of different resources to help you pay for some of this. So Livestrong just started a new program to help survivors go through IVF to save eggs and embryos, so that if someone's going to lose their fertility in a short time, this will help pay for some of those medications. We also are big proponents of billing appropriately. So if you go see a reproductive endocrinologist or a reproductive urologist, tell them you're not a general infertility patient. You are not. They need to code you under having a history of a medical disease. And typically those codes now are so specific that they can really line that out, or they can use something called a family planning code. So that was it. I think 5 minutes. I did it. Yeah. So I'm certainly happy to take any questions in this setting, but also happy to talk one-on-one if that's a little bit better for you. And I just wanted to give you my email as well as my phone number, so that if you've got any questions or want to chat further, you can absolutely call me. You can email me. I'm happy to discuss things either way. Thank you. Yeah. Not that we've found out so far, but doing like with testicular tissue banking, where we're isolating some of those spermatogonial cells, it's still in its very infant stages. There are kind of two big labs here in the United States that are really pushing for this science. And right now it's been more about trying to isolate those stem cells so that we can repopulate a testicle in the future. It's been more about trying to do it in vivo or in the body, as opposed to, yeah.
I just kind of added also one phenomenal talk about. I want to add just one quick comment in, because I did not talk about contraception. We didn't have time for that. But the anti-Mullerian hormone, we also used it for the opposite purpose. You know, we use it to see if someone is able to get pregnant. Sometimes I'll have a cancer survivor come to me and say, I'm not sure. I don't want to get pregnant. Do I need contraception? And I start with an anti-Mullerian hormone, because if it's essentially not there, if it's extremely low, I tell them they don't need to use contraception. So there's that side of it as well. Not, you know, for those who aren't trying.
Yeah, so that's a great question. Can you donate eggs if you're a cancer survivor and you have them frozen? And the truth of it is you probably could, but I don't know how many people would use them. So when you go to find an egg donor, they want a full health history. So whoever's going to use those eggs is going to want a very detailed health history. And oftentimes, if they see cancer in there, even though we know that the vast majority of these cancers have nothing to do with our genetics, if they see that in there, oftentimes they'll say no. They don't want them.
It's true of any medical illness. I mean, when people are buying sperm and eggs, they're buying to get, you know, healthy sperm and eggs. So it's not just in cancer survivors. I mean, I've gone through this with so many patients. Anything, you know, if he likes Beethoven instead of Bach, they're like, I don't want that sperm. You know, they're picking. They're like, you know.
They're very specific.
Very specific.
Yeah. Thank you so much.
There's another question.
Oh, I'm so sorry. So both difficult issues. And I think on the cancer survivor side of things, it's getting better. So if you were to look at this 10 years ago, as a cancer survivor, can I adopt? Oftentimes the answer was probably not. And it's because many adoption agencies just really didn't understand what it meant to be a cancer survivor. But as we're getting better at treating and curing cancers and getting better at managing cancers, we're finding that that's not the case. So the Fertility Consortium actually did an adoption study where they called agencies and ran through a questionnaire with the agencies to determine if they would adopt to a cancer survivor and what that looked like. And for many of them, the adoption agencies want a letter from your oncologist stating you went through treatment, things look pretty good now. For the most part, it's not an issue, at least in these agencies that we worked with. I've certainly had patients who have had this issue and they've not been able to adopt through a specific agency. They've gone somewhere else and they've had success. Adopting as a single person can also be very difficult. So I can tell you most international adoption agencies will not even look at you if you're adopting as a single person. Sometimes here in the United States, that's the case as well. Where it doesn't get to be as much of an issue is if you sign up through, kind of being a foster care person and go through adoption in that route. Oftentimes, they are not so strict on this sort of ideal family from the 1950s kind of thing.